So now, without further ado, it is my pleasure to welcome today's speaker, Eric Blouin, a Senior Vice President with Ipsos Healthcare. Eric, you have the floor.
Thank you, Ellen. Well, looking at today's agenda, we have only 30 minutes and it is quite a packed agenda. So we're going to jump right into it. And I even forgot to say good morning or good afternoon, wherever you may be in the time zones. I do want to say before we start that this webinar today is going to give you a very broad overview of the fundamentals of oncology. However, things are moving at a breakneck speed in this space, and things change very, very quickly. However, because we are dealing with the fundamentals, they should still apply and help you with your knowledge over the near future. So let's get into it. What is cancer? It has plagued humanity since antiquity. So the first example, the first documented case of cancer dates back to 1200 BC in a mummy that was uncovered in Sudan, where there was evidence of cancer. And if you look at the scope of it, the WHO estimates that 10 million people will die from cancer in 2020, or had died from cancer in 2020. And looking at COVID, which of course we all experienced over the last few years, that's 4 to 5 times more deaths than COVID in that 2020 time period. The word cancer comes from ancient Greek. It comes from kertinos, and that was a term that Hippocrates used because he felt that the invasive tumors look like crabs because of their tentacles, or the tumor's tentacles or arms or legs. And another Greek word brought us to oncology, which is onkos. And that was another Greek philosopher, physician, Galen, who felt that tumors swelled and called them onkos. So that's a little bit of the history, but let's talk about what it is from a scientific perspective. Quite simply, cancer is the uncontrolled replication of poorly differentiated and non-functioning cells. And what happens is these cells crowd out the healthy tissue, they spread to the rest of the body, and essentially lead to death because it prevents the organs and the body from functioning normally. It's important to note that cancer isn't monolithic. It's not one disease. It's actually one term that encompasses many, many different types of diseases. What causes cancer? The proximate cause is mutations. Not a single mutations. You don't get cancer because one of your cells develops a mutation. It's actually a sequence of mutations or an accumulation of mutations as you age. And it can range anywhere from 2 to 10. And this essentially leads to that uncontrolled growth that I referred to on the earlier slide. But what causes those mutations? Well, there are many distal causes. I'm sure a lot of you have heard of lifestyle choices being linked to cancer. Things like alcohol consumption, smoking, high-fat diet, lack of exercise, or sedentary lifestyle, as well as radiation. UV exposure is very well linked to skin cancer and melanoma. Environmental factors such as pollution and other pollutants. But what is maybe less known is that we've also discovered that there are pathogens that cause cancer. Viral pathogens like HCV and HPV, which are hepatitis B and C, very well documented as causes of liver cancer, as well as HPV, which is the human papilloma virus, which cause cervical and head and neck cancers. And in fact, we have very effective preventative treatments against infection by HPV that have helped reduce the cases of cervical and head and neck cancers in the population. There's also bacterial and parasitic involvement. So as you can see, a lot of different causes, and not a single one necessarily predominates. And sadly, age is a major has a major role in cancer. So on the chart on the right, you can see both male and female rates of cancer incidence by age, and there's this sharp increase after age 50. And that's quite simply because not only do we have that amount of time to accumulate mutations, as I mentioned, but the body, as it ages, loses its ability to repair itself, as well as loses immune function, where the immune system can essentially destroy individual cancer cells before they spread. The last cause is inherited. There are certain genes that are passed on from parents to child. And due to these mutations, they provide or they lead to a higher likelihood or higher incidence of cancer risk. And the most widely known of this is BRCA1 and BRCA2, which leads to higher likelihood of developing breast or ovarian cancer in women. It's about 10 to 15% of cancers that are estimated to be of hereditary causes. So it's not a major component, but still a sizable one. Now that we know what is cancer, let's talk about the different types of cancer. So we tend to classify cancers into two major categories based on the organ type. So solid tumors are those that originate in organs such as breast, colorectal, lung, or other major organs and systems. Whereas hematological malignancies are cancers of the blood and cancers of the blood cells. So in that you have leukemias, lymphomas, plasma cell cancers like multiple myeloma, as well as myeloproliferative neoplasms. But it's important to keep in mind that there's actually about 80 different types of cancers, even when you break them down into those organ systems. So there's not just one type of brain cancers, there's several types of different brain cancers. And this is all based on the type of cell that is involved in the initial tumor. We'll next move on to cancer staging. What is cancer staging? Well, it's determining, once there's a diagnosis of cancer, just how far the disease has spread and how big the tumor is. Those factors are extremely important, as you'll see later on, in terms of determining both prognosis and the treatment approach. And that's because a small localized tumor that hasn't spread is potentially curable. Whereas a large tumor that's spread to other parts of the body is not. And then the goal changes to one that is not cure, but to extend life. The way we stage solid tumors is based on a system called a TNM system. And it's based on three factors. So T stands for the size of the tumor. Essentially, it is given a number, either T1, T2, T3, T4, based on how big the tumor is. And this is assessed through imaging, such as MRIs or CT scan. Next is N, which stands for nodes. And this is the number of nodes that are involved. By involved, we mean when there is a biopsy done in the local nodes around the tumor or around the organ, we can determine whether or not tumor cells are found in these lymph nodes or not. And you'll understand in a moment why this is so important to, again, classify as in whether there's nodal involvement or no nodal involvement. And finally, the M stands for metastases. And that is really, are there any distant metastases that are seen on imaging, such as to the brain or to the bones, or is that absent? And the reason why I mention nodes are very important is because that is how the cancer, the original primary tumor, spreads to other locations in the body. Essentially, cells detach themselves from that initial primary tumor, and using the circulatory and the lymphatic system, move to other sites in the body. Now, it doesn't mean that just because they move to other sites that other tumors will develop, but over time, that is what happens. And the most common sites of metastases are bone, brain, liver, and lung. And it's very important to note, though, that these are still essentially clones of the primary tumor. So even though you may have a primary tumor in your lung that then spreads to your brain, the tumors in your brain are not brain tumors. Those are still lung tumors that have metastasized to that site and can be treated with the same medications and same approach as you would for lung cancer. So using the TNM guidelines, a doctor will look at classifying the patient's cancer into the AJCC classification system. So they'll take guidelines, which are data-driven, and based on what the number of the T, N, and M are for that patient, they'll essentially determine whether they are stage 1, 2, 3, or 4. And it's important to know this because this helps to, again, set the treatment paradigm for that particular patient, as well as determine what sort of prognosis. Hematological tumors have very different staging systems. So they don't use a TNM because it just wouldn't apply to them. So instead, there is staging systems that are unique to each disease. So you'll see a few examples here for NHL, for multiple myeloma, for CLL, and these are all based on looking at specific factors that are unique to each of those diseases. All right, let's move on to treatment overview. So there's a lot of different factors that an oncologist will take into consideration when assessing a patient and how to treat them. Histology. So as I mentioned, it's important to know, well, what is the source of the primary tumor? Because the source of the primary tumor will tell you exactly what sort of treatment to consider. The stage, is it large, is it localized, or has it spread? The grade, how aggressive is the tumor? And this can be seen under microscope because higher grade tumors, those that grow faster, have even more undifferentiated cells than lower grade tumors. Location, so even for tumors that may be localized, in some cases, it's impossible to operate because there may be a major artery too close to it, which would make it impossible to remove the tumor. The performance status, how fit is the patient? A patient who's very fit can undergo more aggressive and undergo treatments that may have more toxicity, but also more efficacy. One that's more frail will probably not be able to undergo those aggressive treatments. Biomarker status. Biomarkers are either mutations or genetic aberrations or receptors that are present in the tumor cells. And as you'll see a little bit later on, we're at the point where now we can tailor treatment to those specific biomarker that are found in particular tumors. And then there's many other important factors like patients' wishes. Some patients want to fight hard, others want to be comfortable and have good quality of life in their remaining time. Convenience and also payer access and economic factors can all implement. As I mentioned, if you look at why staging is so important, early stage tumors, in general, the goal is curative. There will be surgery involved unless there's a reason why surgery cannot be conducted. And a patient may receive neoadjuvant or adjuvant drug therapy before or after surgery to help reduce the risk of recurrence, or to help make the operation, the resection, even more successful by shrinking the tumor before surgery. However, patients do relapse, and when they relapse, it's generally because there's metastases that show up in different parts of the body. Also, in certain cases, and more prevalent in certain tumors, the diagnosis is made where the disease has already spread. It wasn't caught in time. In this case, the more common modality that's used is drug treatment, with radiation and surgery really being used more for palliative purposes. The goal is not the cure at this stage, it's to extend life. If we look at the drug treatment classes that are available, there's a lot now. It used to be that it was basically chemo. It was a cytotoxics. Everyone's heard of chemotherapy, and that really became of age in the 50s and 60s. Anti-hormonal treatments are used for breast and prostate cancer, and those came a little bit later in the 70s, and are still used pretty much for those two tumors. Really in the 90s and in the aughts is where we see the rise of targeted therapies, which is drugs that target a specific receptor or protein in the tumor, as well as immunotherapies. And these drugs don't actually act directly on the tumor. Instead, what they do is harness the immune system to go and then attack the cancer cells themselves. So we'll go into a bit of details on all of these. I do also want to mention that along with these anti-cancer drugs, oncologists use a host of supportive therapies. So these are drugs that are help counteract the negative side effects of the anti-cancer drugs or of the tumor itself. And they include blood cell growth stimulants, antiemetics, bisphosphonates, and antibiotics. So one note on chemotherapy. Historically, the term was often used interchangeably to describe any cancer drug, but because we have all of these other classes now, it's more accurate and less ambiguous when you speak about it to refer to this class as cytotoxic therapy or cytotoxic chemotherapy. And that's, the word cytotoxic simply refers to how chemotherapy acts, which is it interferes with DNA replication and cell division. Hence, it kills the tumor cells because those are dividing quickly. Unfortunately, it also kills healthy tissue that is also dividing quickly. And that's why you have side effects like loss of hair, like frail skin, like nausea and diarrhea because of the epithelium lining your digestive tract is also tissue that turns over very quickly. So let's talk about targeted therapy or precision medicine. Historically, we treated every patient pretty much the same way, depending on what kind of cancer they had. So if you had lung cancer, you pretty much received the same treatment regardless of many of the factors I've mentioned. However, technology has really made changes to our acquisition of data and to also building up huge data sets, and also helping us understand how cancer arises, grows, and spread on a molecular level. And because of that, we've been able to identify novel targets for cancer drugs to act upon. And in fact, disrupt the molecular factors that are allowing the cancer to grow. So I'll give you an example. I brought up non-small cell lung cancer. So prior to 2010, essentially all patients, once they were diagnosed with metastatic non-small cell lung cancer, would receive chemotherapy. Some would have a good response, some would have no effect, and some would have adverse effect, where the cancer would grow or they couldn't tolerate it. In terms of the present, the first step that's done is actually to sequence the tumor DNA. And that will allow the physician to understand, is there a specific molecular profile that would lead to a specific targeted treatment to be used in that patient? And the goal is to have that positive effect in as many patients as possible. So targeted therapies can be categorized into two broad categories. One is monoclonal antibodies. So these are antibodies that are manufactured to target a specific receptor that is found outside of the tumor cell. And by doing so, it either flags it for destruction or prevents any sort of other ligand to attach and stimulate growth in the cell. The other categories are small molecules, and small molecules actually can penetrate the cell walls, and they actually act on the intracellular pathways. So they will hit one of these intracellular proteins that actually is part of a pathway, either for cellular growth or in terms of preventing cell death. So by inhibiting these, you can either promote cell death or you can disrupt the growth through this process. There's a third category, which is actually called an antibody as well, and it's actually called antibody drug conjugates. So these are literal smart bombs where you have a cytotoxic molecule that's attached to an antibody that's directed against, again, a specific receptor on the cancer cell. However, once it binds, what happens is the cytotoxic molecule cleaves off and can then penetrate the cell itself. And the thought is that by being so specific, they're sparing the healthy tissues and only targeting the tumor cells. So I liken it a little bit to, World War II, where you had carpet bombing, versus modern warfare, where now you have targeted smart bombs that will home in and only destroy the enemy tanks or enemy bunker. It's very recent. The first ADC was approved about 20 years ago, but there was only 2 others that were approved over the next decade. And really the renaissance or the inflection point has been in the past 5 years, where we've seen now nearly 10 different ADCs be approved as the technology has matured and has proven to be able to deliver better results. And there's a newer class called that's similar, called radioligand therapies. And instead of a cytotoxic molecule, the antibody has a radioactive isotope. So same concept, where it's targeting the tumor very specifically with this radioactive isotope to disrupt cellular growth, but not the healthy tissue. So to close off, I do want to go through the other major class, which is immuno-oncology or immunotherapy. And there's several different subtypes of immunotherapies. The more recent ones are the checkpoint inhibitors and the cell therapies. But as you'll see from this slide, cytokines as well as therapeutic vaccines have been around for quite a while. However, again, with understanding the molecular process by which cancer cells evade immune recognition and destruction, we were able to develop treatments in the last decade that specifically try to override the systems that the tumor cells use to hide themselves from the immune system. And if you take away one thing today about immunotherapy, it's the class that's called anti-PD-1s, L1s. It's an immune checkpoint inhibitor, but as you can see from this slide, it's one that's been quite active. The first was approved in 2014, and that's Keytruda, which I'm sure many of you may have seen on TV if you live in the United States, where DTC is allowed. And since then, Keytruda has garnered 31 different indications in 8 years. So it's become a fundamental part of cancer treatment. And if you look at all of the other similar molecules that have been launched by companies, they can be used in 21 different tumor types. So a broad use. And the important thing as well from a commercial perspective is that last year, the total sales worldwide for these 7 agents was $33 billion. So it just shows how important this has become in the treatment of cancer. The other category that's very recent is cell therapy. And the ones that are known are called CAR-Ts, or chimeric antigen receptor T cells. And essentially, these are your own T cells that are extracted, modified genetically to recognize a specific receptor that are found on the lymphoma or leukemia or myeloma tumor cells, amplified in the lab, and then reinfused into the patient. And these are one treatment only, or one course only treatment, whereas you don't have to do this many times. You do it once, and patients have had fantastic responses to this as the T cells seek and destroy the tumor cells in the circulatory system. And in fact, for some patients, those T cells continue to replicate in the body. So essentially, they are truly a living drug because they are part of you and stay part of you. So it sounds like science fiction, but in the US, there are 6 different CAR-Ts that are approved now by the FDA across 4 different hematological cancers, and many more in development. So to close off, in the next few years, you're going to see more and more immunotherapy in terms of novel mechanism of action, novel cell therapies that are going to be developed with other types of immune cells, and also off the shelf, which would mean there was no need to actually harvest the patient's own cells and go through that process that I described. We might see cell therapies for solid tumors, as well as cell therapies that serve as surrogate donor sources for stem cell transplantations. The other exciting one is in the second box, which is multi-cancer early detection tests. And this offers the promise of a simple blood-based screening test for multiple types of cancer at once. So it may become part of your annual physical in terms of screening for cancer and hopefully detecting cancer very early on where it can be cured. And in the US, there's already one of these that has reached the commercial stage and is available on the market. So what does this all mean for you? Well, I mentioned this at the beginning, I'll mention it again. The pace of change means that forecasts and market knowledge must evolve constantly. Market direct disruptions can happen very quickly, and assumptions that were made a few months even earlier can sometimes not be accurate. So everything needs to be stress test. Always remember, this is a therapy area driven heavily by data and guidelines. And because of the pace of development, because of the opportunity offered, the marketplace is becoming far more crowded than it used to be. Many companies are developing assets that may have not been in the oncology space in the past. We're also seeing growing involvement of patients in their own treatment choices and their voice being heard. It used to be that you had cancer, you relied on your doctor, and you followed the doctor's advice. But through advocacy, through education, patients are becoming much more part of their own treatment. It's important to also note that while we've made a lot of forward progress, there's unfortunately increasing inequity in access to these more recent developments in terms of targeted therapies and immunotherapies. And again, the growing complexity of cancer treatment is a challenge for everybody. If you have trouble trying to keep up to date with oncology, just imagine the oncologist who has to also treat patients and stay up to date. So this is also a place where we have to be mindful that we can't assume that oncologists, even though they're specialists, will know everything and anything that has changed in terms of the treatment approach. I want to thank you for joining today. We went a little bit over time. As I said, it was a very packed agenda, but I will take a look at the chats. I know there may have been questions, and I will answer questions by email in the coming days. So again, thank you for joining, and I hope it was a worthwhile investment of your time.